Ooh. Okay, well, let's go ahead and get started this morning. I'm sure people will keep wandering in. I'm terribly excited about the topic for today's lecture. I can remember, like, even during my own training, which is a long time ago, the oncology groups, already together had formed their little organizations, ECOG, SWOG, other exciting names like that. The last two always being something oncology group. So they have a very, very long tradition of clinical trials in oncology that are nationwide and have allowed them to progress. Before I ask Dr. Riley to come up and introduce the speaker, Jason Puckett had reminded me that I totally forgot to announce the names of last month's Grand Rounds attendance winners. So we have two. One of them is Dr. Raghuram, and the other is Nancy Kubiak. So the two of you guys, can see Jason Puckett and pick up your Panera gift cards. And with that, I'm going to ask Beth to come to the podium.
Thank you, Dr. Lederer. So it's my pleasure to introduce a colleague, friend, and someone I admire very much, Dr. Rebecca Redman. Rebecca came to the Brown Cancer Center shortly after I did, so we have grown up together as faculty. She is an amazing clinician, has won awards both for teaching as well as her clinical skills, but where she's making the biggest mark is actually in the development of our phase 1 clinical trial program. So recently she was named Deputy Director of Clinical Research. She is single-handedly rebuilding our early phase clinical trial program and is somebody we're very lucky to have on faculty. So, Rebecca.
All right. So I'm going to remember to stay by the podium because I don't have a mic on. So phase 1 oncology trials, hope or hype. So I'm going to start with a little bit of history of why we're here. So rewind to the 1930s, and sulfa was just discovered as an antibiotic. And it was quite successful in adults, and as you can imagine, getting children to take tablets, that was difficult. So someone had the brilliant idea that, gosh, if we could come up with a liquid form of this, wouldn't this be great for children? So they discovered Sulfanilamide Elixir. And you can see 10% actual drug, 72% diethylene glycol, and then 16% water. They flavored it with some raspberry extract to make it taste really nice and make it look nice and bright. And shortly after it was released, very quickly people started dying. A number of them were children. Anybody know what diethylene glycol is, otherwise known as antifreeze? Yeah. So the company, interestingly enough, the FDA at that point was not actually tasked with safety. And so they really had very little power over the drug companies at that time to take things off the market. So actually they got this drug removed from the market based on a technicality. Elixir at the time meant that it had to contain ethanol, which this product did not. So they basically got it removed from the shelves primarily based upon the fact that it was labeled as an elixir, which it was not at the time, and the company was fined a nominal fee because of that. But it really kind of set the stage for what we know today as the FDA, and really set the stage and planted the seed for phase 1 trials to demonstrate safety in humans before drugs make it to market. It really, actually, interestingly enough, wasn't until the 60s that the FDA mandated demonstration of efficacy for drugs to make it to market. So this is a picture of Dr. Frances Oldham Kelsey. So this is kind of an interesting story. So she is from Canada initially and moved to the States, to the University of Chicago to get her PhD around the time that the whole sulfanilamide disaster was taking place. And interesting, the lab that she was working in at the time was tasked with evaluating the elixir to figure out what the toxic component was. And so she was pretty instrumental in identifying why it was that sulfanilamide was toxic. Fast forward a number of years, she went on to get her PhD and MD, and then actually was recruited by the FDA to be one of the first medical officers that worked for the FDA in the 50s. And interestingly, was one of the only reviewers to review the Kevidon new drug application. Anybody know what Kevidon was? Kevidon was thalidomide, which was being marketed at the time for nausea in pregnant women. And her comment was that their application was an interesting collection of meaningless pseudoscientific jargon, apparently intended to impress chemically unsophisticated readers. So despite a lot of pressure from the pharmaceutical companies and the powers that be, she kind of stood her ground and would not approve thalidomide in the United States, and probably single-handedly spared the United States from much of the thalidomide disaster that took place in Europe. She actually then went on to become the director of the Department of Scientific Investigation, which is tasked with overseeing clinical trials and clinical investigators, and then retired at the ripe old age of 90 from the FDA. So she really had a huge part in why we do phase 1 clinical trials nowadays, and really the development of the whole clinical trial process. Okay, so this is just a quick tutorial on how do we run phase 1 trials. And this is kind of the old-fashioned way, but still by far the most common way oncology phase 1 clinical trials are done. So this is the classic 3+3 design. And you can see basically 3 patients are enrolled at a given dose, and then those 3 patients are treated for what we would consider 1 cycle, so usually several weeks. If there are no dose-limiting toxicities, you go on and you enroll 3 patients at the next higher dose. If there is 1 out of 3 patients who have a dose-limiting toxicity, you would then enroll 3 more patients at that same dose. If it's only that 1 out of 6, then you go ahead and you escalate to the next dose. If there is more than 1 person out of that cohort of 6 who have a dose-limiting toxicity, that is considered your maximum tolerated dose. And then you basically back down from there. This is kind of the way it's been done for years, and is actually quite simple. One of the problems and the criticisms of this, of course, is that you're only considering the current cohort that you're examining at that time, almost irrespective of what happened in previous cohorts. And there's a lot of other issues that come about in the era of targeted therapy. The maximum tolerated dose, then usually either that dose or slightly lower, goes on to become the recommended phase 2 dose. So is this design outdated? That's the question. So, the traditional 3+3 dose escalation design assumes that higher doses are associated with higher efficacy, right? So back in the day of cytotoxic chemotherapy, that was probably true. The more drug the tumor sees, the better, but you just don't want to harm the host in the process. Again, it only considers the last available cohort, so the last 3 or 6 patients. Once you move beyond a cohort, it's sort of like those patients are lost. The question really is, do we need to dose to toxicity in the era of targeted therapy? Can you hit your target without causing, other dose-limiting toxicities in the patient? So this was a study done at MD Anderson, and they took 24 consecutive phase 1 studies and went back and looked at that. It included about 680 patients, and this was in 2004 to 2008. And they looked at those patients who were treated on study who received what they considered low dose. So basically, they received a quarter, 25% or less of what was ultimately determined to be the maximum tolerated dose. And then those that received high dose, which they received at least 75% of what was determined to be the maximum tolerated dose. And they looked at disease control, so patients whose disease had not progressed at 90 days. And you can see that it's pretty darn similar. 32% of patients who received the low dose had disease control, and 25% who had received at least 75% of the maximum tolerated dose. And not surprisingly, more patients who received the high dose came off study for toxicity. So 16% came off for toxicity within 12 months, whereas only 2% of those who had received the low dose, and that makes sense. But it really, raises the question of nowadays with targeted therapy, do you really need to dose to maximum, to the maximum toxicity? Can you get away? Is there some medium endpoint that we can use to evaluate for what the recommended phase 2 dose should be without dosing to toxicity? So there are some other things that have been proposed, something we refer to as the biologically effective dose, and that's based upon evidence of target inhibition. The hard part about that is you have to have something that's easily accessible. So doing tumor biopsies every 2 weeks is generally frowned upon. So you have to have a target that you can measure, say in the peripheral blood, to say that your target has been hit. Also, we don't know what level of target inhibition is required to get a clinical response. Do you need 100%, 80%, 20%? So that becomes really difficult. There are model-based designs, which are statistical modeling that basically incorporates individual patient data, so real-time data to assess the risk of toxicity at any given dose. Those are a little harder. They're not as intuitive, a little more complex. Certainly, there are many advocates of these in the field. And in theory, minimizes the patients that are treated at a subtherapeutic dose. It allows you to escalate doses much more quickly and identify toxicity much more quickly. But for logistic reasons, have not been adopted as much as you would think. So why is oncology unique? When we talk about phase 1 trials, most of the time, the first thing you're thinking about is safety, right? And so the difference, though, is oncology drugs are not typically tested in healthy subjects, right? So there is usually significant risk that comes along with a lot of oncology therapeutics. And for that reason, really not thought to be ethical most of the time to test those in healthy subjects. Although safety and dose finding is our primary objective of any phase 1 study, there is almost always, in fact, I would be so bold as to say always, efficacy listed as an objective endpoint. And part of that is if you are going to subject a patient to the risks of a new drug, you want to at least hope that there is some potential of benefit and look for some signal of efficacy. So efficacy is almost always a secondary endpoint of a phase 1 trial. So we'll talk a little bit now about how phase 1 trials have evolved in the era of targeted therapy. So there's a lot of emphasis nowadays on biomarker design, right? Find the right biomarker. If you can find the right biomarker, you can eliminate risk to those who won't benefit, and you can provide benefit to the patients who really will get benefit. So the pros, of course, minimizing exposure to those unlikely to benefit. If you have a HER2 targeted agent, and you're giving it to patients whose tumors do not express HER2, they are probably unlikely to benefit, right? But if you select for those patients who have high levels of HER2 expression, they're more likely to benefit. You can also accelerate drug development that way. So larotrectinib was recently FDA approved based on an article in the New England Journal, but data that was compiled from phase 1 and 2 studies of 55 patients. 55 patients with NTRK fusions. Their data was compiled, and the response rate, and we'll talk about what I mean by that, was 75%. Based on that alone, it got FDA approval. So talk about accelerating drug development. If you find the right biomarker in the right niche, there was a very small number of patients and a very small number of trials that were required to bring that drug to market. So the cons, you can potentially exclude patients who might benefit. How do you know what the biomarker really is? So the example I'll give you is EGFR overexpression. So cetuximab is a monoclonal antibody against EGFR. And so the natural thought was, well, gosh, those patients whose tumors overexpress EGFR are going to be the most likely to benefit. When they limited enrollment to those who had EGFR overexpression, you certainly saw a benefit. However, when someone looked, if you actually look at the pathway of how EGFR, the growth pathway actually functions, they realized that there may be patients whose tumors do not overexpress EGFR who may still benefit. And sure enough, this was a very small study, but they looked at patients whose tumors do not overexpress EGFR, and lo and behold, the response rates were actually quite similar as those whose tumors overexpressed EGFR, which was pretty eye-opening. And so one of the downsides of starting with biomarker-driven designs in very early phase studies is that you can actually miss patients who may benefit. And you never actually validate your biomarker, right? Because if you never enroll patients who don't have that biomarker, how do you know you have the right biomarker? Also, enrollment can be challenging. So if your biomarker is infrequent, NTRK fusions, for example, are present in only a few percentage of patients. enrollment in these trials can be challenging. You have to enroll a large number of sites to get a very small number of patients. So really quick, for the non-oncologists in the room, we talk about response rate quite a bit. And so, even in the hospital, you'll hear, well, this person has a 20% chance at responding. What do we actually mean by that? So RECIST 1.1 is a way we measure tumors, an objective way of measuring response in the setting of a clinical trial. So a complete response, which is best case scenario, is that disease is no longer apparent on imaging, no longer measurable. A partial response is when their tumor burden decreases by 30% or more. So basically there are some pre-specified or pre-identified target lesions that are identified on enrollment. You measure basically the diameter of those lesions and then take their sum. If that sum decreases by 30% or more, that is a partial response. We talk about objective response rate. We mean the combination of partial responses and complete responses. If you ask me, that probably underestimates the potential benefit of a drug, right? Because maybe there's somebody whose tumor decreased by 20%, 10%, or maybe even stabilized. But still, there's some potential benefit there. But regardless, when we talk about the likelihood of a response, generally you're referring to a combination of the complete responses and partial responses. Progressive disease is when their tumor burden increases by 20% or more, and then stable disease is none of the above, everything in between. So somewhere between 20% growth and 30% decrease in size of their tumor burden. There is a term referred to as clinical benefit, which you will sometimes see, which combines stable disease, partial response, and complete response. So this is from the UofL ICF template, and I took this a little bit a while ago, but I think it still applies. So this is specifically with respect to phase 1 studies. So if you're conducting a phase 1 study, the template language is the first human tests of investigational drugs or therapies occur in phase 1 trials. Phase 1 trials are designed to determine the best dose of the study drug and to check for any potential side effects, which I think is a very accurate statement. These trials usually involve small numbers of volunteers. Because some phase 1 trials use study treatments that have never been tested in humans, they may involve significant risks. You may not personally benefit by participating in this study. The information collected may not benefit you directly. However, the information may be helpful to others. So this really, the intent of this is to make it pretty clear that the primary objective of a phase 1 study is dose finding and safety. It is not efficacy. That said, there are very few cancer trials, as I mentioned before, that don't include efficacy as an objective. So what I would go out on a limb to say is that the scientific objective of a clinical trial does not determine whether or not it offers a potential benefit to a patient. So I may have a specific objective in mind when I design a study, but whether or not it actually benefits that patient has nothing to do with my objective, right? And so when I'm looking at designing a phase 1 study, of course, you're looking at safety, but for those patients, there's obviously also going to be a question of what is the chance that this will benefit me? So what is the potential benefit to patients? That's really the big question. So when I was growing up in medicine, what was always told to me is that your likelihood of benefiting from an oncology phase 1 trials is about 1 out of 20 patients, somewhere about 5%. The likelihood of dying as a result of toxicity from a phase 1 trial is about 0.5%, so about 1 out of 200. And that was the classic teaching for years and years and years, and mostly came about from many of the trials that were done with cytotoxic agents. And the question is, do those numbers still apply? Now with more novel designs, with targeted therapy, with dosing perhaps to a biologically effective dose and not a maximum tolerated dose, are those numbers different? And are we smarter? Do we do a better job? Is the likelihood of benefiting greater than 1 out of 20 patients? So this is back in the early 2000s. This was a study where they reviewed all adult NCI sponsored. So these are going to be mostly cooperative group, the SWOGs, the ECOGs, the RTOG. These were NCI sponsored phase 1 trials from 1991 to 2002, so about a decade. There were 460 trials, nearly 12,000 patients. And they looked at purely response rate. So you can see that the response rate, complete response and partial response, was actually 10%, 10.6%. So a little bit better than we would have anticipated, and we can talk a little bit about why that might be. When you add in the stable disease, you actually, that clinical benefit rate, you got pretty close to 40 to 50% of patients had either stable disease, partial response, or a complete response. So that was actually pretty eye-opening. It challenged the belief that we had held for years that that was closer to a single-digit percentage. Now, that said, one size does not fit all. So remember, a phase 1 trial doesn't have to be a first-in-human drug, right? It can be a combination of two agents that have never been used in combination before. It can be an agent used together with radiation, for example, that we don't know how safe it is to use with radiation. So when we design a phase 1 trial looking at safety, it doesn't have to be a drug straight out of the lab. It could be a new combination. And that really does actually affect what the likelihood of someone benefiting from that combination is. So if you look at cytotoxic single agents, and there are fewer and fewer of those nowadays, but they still exist, kind of the old teaching holds the overall response rate 4.4%, so about 1 out of 20 patients actually benefited. If you add in an FDA-approved agent, so you take a new drug plus a drug that's been FDA approved, you actually increase your response rate to 16%, which makes sense, right? So if you're taking somebody who, especially someone who is naive to that FDA-approved agent, and then you add in another drug, you're going to increase the likelihood of them responding. If you're looking at receptor or signal transduction, again, as a single agent, around 3% benefit. If you add in an FDA-approved agent, it's closer to 11%. And for anti-angiogenic agents as a single agent, right around 4%. You add in an FDA-approved agent, and it was 15%. And deaths that were either possibly, probably, or definitely related to treatment as deemed by the investigator at the time was 0.49%, 1 out of 200. So in a way, this confirmed what we had always thought, but it did really hit home that not all phase 1 trials are the same. If you're talking about a new drug, a first in human, first in class, that old dogma of 1 out of 20 patients benefiting is probably true. If you start talking about adding other drugs or looking at combinations, you probably have actually a better chance of benefiting. So the same group updated this data a few years ago, where they looked at the next decade. So they went from 1991 to 2002 and now to 2001 to 2012, which really enters the era of targeted therapy. And again, the question is, are we getting smarter? Are we designing trials better to benefit those patients who are more likely to receive benefit? And you can see the response rate went from 10.6% to 13.2%, so slightly better. Disease control, that includes those with stable disease, was a little bit better. But interestingly, despite the fact that these are now targeted therapies, we're thinking that they're less toxic, perhaps not even, many trials don't even reach their maximum tolerated dose. The death rate was actually a little bit higher, about 1%. And those with a grade 4 adverse event, which are generally considered to be life-threatening, that was as high as almost 20%. So about 1 out of 5 patients had a fairly toxic adverse event. This is another study that, again, tried to get a sense of more current time. What is the current likelihood of benefiting from a phase 1 trial? And this was a study that looked at did a PubMed search of any phase 1 trial. So this included industry-sponsored studies going from January 2014 through June of 2015. And you can see about half were industry-funded. 38% were truly first-in-human. 60% actually were a combination of various treatments. And then 13% were biomarker restricted, so used some type of tumor biology to drive eligibility. The overall response rate for this time period was 20%, which quite honestly mirrors what we see as response rates for many of the standard chemotherapeutics that we use nowadays. I don't know if that buzzing is me. High-pitched buzz, okay. When you look at what factors were associated with an increased likelihood of response, you can see if the trial was limited to a single tumor type. So if you said this study was going to be just for patients with lung cancer, perhaps there was something about the biology of the drug that suggested it would benefit lung cancer patients the most. The odds ratio was actually 2.39. If you were able to restrict eligibility based on a biomarker, based on tumor biology, you also had an increased likelihood of benefiting, and again, a combination. So if you were combining multiple drugs, the likelihood of benefiting was greater. So here's the question. Does personalized medicine really translate to increased benefit? So this was a study of 1,500 consecutive patients that were seen at MD Anderson and referred for a phase 1 trial. 1,200 of those actually had tissue available for profiling, and of those, a surprisingly high number, a little more than half, had an alteration that was potentially targetable. Those patients were then put on various clinical trials. Unfortunately, for some of those with an alteration, there may not have been a trial at the time that matched their alteration, or perhaps the cohort was filled at the time. And so about 2/3 of those that, even though they had an alteration, they did not actually go on a trial that targeted that alteration. So about 236 went on a non-matched treatment, 143 went on a matched treatment, if the others either were not eligible or chose not to go on study. So, response rates. Complete response and partial response for those who received a matched therapy, 12%, which again starts to get very close to what we would consider response rates for second or third line treatment in patients with metastatic cancer. Those with non-matched therapy, back to the 5%. Progression-free survival. So how long did they live before their tumors progressed? 3.9 months in the matched therapy, 2.2 months in the non-matched therapy. 6-month progression-free survival. So went for 6 months without their tumors progressing, 16% of those on matched therapy, 12% on non-matched therapy. And then you can see median overall survival with all of the inherent difficulty there is in looking at overall survival in a study like this. But you can see median overall survival was also improved in those who received matched therapy. So I would argue that this shows maybe we are getting a little bit smarter. Maybe those biomarker-driven studies actually are more likely to benefit patients. And maybe that is really, maybe the field really is moving in the right direction. So let's talk about survival, because at the end of the day, response rate is a number, right? And what patients really care about is I want to be alive a year from now. So survival on a phase 1 trial, as you can imagine, is very difficult to evaluate. This is a very heterogeneous group of patients. Who do you use as your control? What's their expected survival? So again, this was 1,200 consecutive patients treated. This was beginning in 2006. 24% actually went on to enroll in more than one phase 1 trial. The median number of prior treatments was 4. So these were patients who were heavily pretreated. Interestingly, 5.6 were treatment naive. So those with cancer types where there really was no standard therapy, the more rare cancer types. And 84% were treated with targeted therapy, which again speaks to where trials are nowadays. We don't really have many new cytotoxic agents that are coming to market. Overall, median overall survival was 10 months. So when we think about the patients that we refer for phase 1 trials, I think it's important to point out that these patients sort of self-select for patients who are going to do better. Generally speaking, patients who are eligible for a phase 1 trial have to have what we consider an ECOG performance status of 0 to 1. So what does that mean? 0 means they have virtually no symptoms from their cancer, and 1 means that they have some symptoms, but they're still able to carry out activities of daily living, some light work or exercise, just, sort of manageable symptoms. When you look at which patients did the best and which patients did not do as well as we'd hope, those who had an ECOG greater than 0, so who were symptomatic from their cancer, in essence, did worse. Those with GI cancer origin, those with a low albumin, those with more than 2 metastatic sites, or a high LDH. Any of those factors predicted for worse overall survival. Those who had 0 factors had a median survival of 2 years. Those with 4 to 5 factors had a median survival of 4 months. And so, I think some of this is what we would expect. Some of it is common sense. For patients who are not doing quite as well, their survival is shorter. But I also want to point out for those patients who really are doing quite well, going on a phase 1 trial is not necessarily we think about who are we referring for phase 1 trials. We're not necessarily talking about patients who have a few months to live. These are patients, again, who are self-selecting that they're in pretty good shape as far as their cancer is concerned. So what are some of the barriers to clinical trial enrollment in general, but specifically with respect to phase 1 trials? So likelihood of benefit is low, risk of toxicity is significant. Some would say it's unethical to put an advanced cancer patient who has limited time on a phase 1 trial. I think many of those patients or others would say that there are many benefits to going on trials, including phase 1 trials, other than just a decrease in the size of their tumor. So hope is one. It's one thing to be realistic, but yet still be able to maintain some hope that there is a chance things could get better. A sense of control, a sense of taking back what they feel has been lost, a benefit to society. How many times, I can't count how many times I've heard, well, this might not help me, but hopefully will help someone else. And 5 years from now, someone else in my shoes will have a different outlook. The increased attention and education. I hear this all the time, more than I would have thought, for patients who come off study, who miss being on study because they miss the attention from the staff and the research nurses, and they're in the clinic much more often than those who are not on trial because they have to come and get their additional labs and PK draws and scans more often. And, the increased attention and education, I think, helps emotionally, but also physically. There's probably better attention and addressing symptoms earlier on, and in a way, better palliation of symptoms for that reason. And then really the question is, who defines low in terms of likelihood of benefit? What is a low benefit? 1 out of 20, 1 out of 10, 1 out of 5? Who defines what the likelihood of a low benefit is? So the second comment is that treatment on a clinical trial encourages a desire for heroic or aggressive medical care at the end of life at the expense of palliation. And I alluded to it previously, but actually I would argue the opposite. So first of all, palliative care and clinical trial participation are not mutually exclusive. So we all should be doing palliative care, right? Palliative care is not synonymous with hospice. And so attention of symptoms and management of symptoms of cancer patients is palliative care. And that is not mutually exclusive with a clinical trial. And arguably patients who are on a trial are seen more often and probably have even closer attention to those symptoms. Secondly, clinical trials, again, self-select patients who desire disease-directed treatment. They're simply not ready for hospice. So it's not like this phase 1 trial is a carrot dangling, keeping the person away from hospice. These are people who are not quite there yet. But clearly not all patients should be encouraged to seek out trials. If I have a patient who has an ECOG performance status of 3, meaning they're in bed more than 50% of the day, and can barely do their own activities of daily living, they're not going to be eligible for a clinical trial. So getting on a plane and flying to Houston to see if they're eligible, that's not really the right thing to do. So that's our job as their providers to really say, who are the right people for these trials. And then interestingly, 84%, there was a study that looked at patients who were consented to a phase 1 trial and asked, and 84% of patients consenting to a phase 1 trial expressed an awareness of supportive or palliative care alone as an alternative, but chose not to go that route. So most of these patients are aware that that is an option, that they don't have to go on trial, that this is simply an option, and that focusing more on symptom management is certainly one other option. The other thing that comes up sometimes is, are patients with advanced cancer a vulnerable population? And that's a loaded word. But when you think about patients with advanced cancer, are they really able to make an informed decision? And so some of the questions that come up is cognitive impairment. So for patients who have been through multiple lines of treatment, specifically those who have had prior brain metastases, cognitive impairment is common, particularly in the elderly. And consent forms are required to be written at an 8th grade reading level. So what is an 8th grade reading level? Is that something, and the documents are getting longer and longer. So reading a 30-page document about all the different risks, that's difficult for anyone, much less someone who's in that situation. A lack of other reasonable treatment options and a limited life expectancy, the mentality of what do I have to lose? often probably does result in an increased willingness to accept greater risk. And then simply field-wide use of statements such as, our best treatment option is a clinical trial. You hear that all the time in oncology. The best treatment option is a clinical trial. And it really is kind of ingrained in our training that the only way you move the needle in oncology is to participate in clinical trials. This is a snapshot from NCCN guidelines, so the National Comprehensive Cancer Network guidelines for treatment of cancer, and this is for patients with head and neck cancer, which is what I treat. You can see that for those who have metastatic disease at initial presentation, the very first option is clinical trial preferred. So in addition to all these things you can do, the very first thing they say, and these are first-line patients, these are not patients who have had multiple treatment regimens, clinical trial preferred. When they get persistent disease or progression, clinical trial preferred. And so we tend to think about clinical trials not as a way of investigating things, but actually as a treatment. And I think sometimes perhaps not intentionally, but presented to patients that way. This clinical trial is a great treatment option, as if it's the best option to treat their disease, not something we're doing with scientific investigation. So what kind of things do influence patient decision-making? So this was really an eye-opening study to me. So this is 160 patients who were consented in a phase 1 trial at 5 different academic sites. So who are the patients here? So not surprisingly, 88% white. Mean age was 58. 96% patients were insured. 51% had some level of college training. Many had lived with cancer for a number of years, on average close to 5 years, and had had 3 prior regimens. So for alternative treatments, how many were aware of hospice as an alternative to trial participation? So 81%, similar to the study I had mentioned previously. So 81% that they said they were aware and had discussed hospice. 6% seriously considered it. So again, these are patients who are self-selecting for trials. These are patients where hospice had been presented as an alternative, but really were not quite there yet. And again, remember, these were patients who were actually consented. So someone had made the determination that they may possibly be eligible, meaning that they had a performance status that was actually reasonably well. How about pressure to participate? Did they feel pressure? So 9% felt pressure from their families to participate in a trial, 7% felt it from their providers, and 75% felt pressure because their cancer was growing. So I think the majority of these patients, again, are patients with very limited options who are looking at ways to treat their cancer and then in that way also hopefully help other folks down the road. This was really interesting to me. So patient considerations of adverse events in trial participation. So they asked, if you knew this would happen, or this was the likelihood of something happen, would you still participate in this trial? If you had a 10% chance of death when you participate in this trial, 1 out of 10 people are going to die, would you still participate? 91% said yes. The obvious comment to this would be, well, I don't have many options, and I have about 100% chance of death if I don't, right? What about impaired ability to think? Interestingly, that was the lowest percentage who would still participate in the research trial. So 76% would still participate if there was an impaired ability to think as a result of the trial. And what that says to me is these are people who are really thinking about things, right? Realizing that they don't have great options and they're willing to accept significant toxicity. But when it's something like an ability to think or their cognitive functioning, when it starts to affect quality of life, people actually think about that, and think twice about, the age-old quality versus quantity. So what that says to me is these are people who are actually thinking about this seriously, but at the same time are willing to accept significant risk. And so this is eye-opening because, as you know, on many clinical trials, and in particular phase 1 clinical trials, there is a list of risks that goes pages and pages and pages. And looking at this makes you wonder how much of that is sort of glossed over when a patient's reading through it. Because if they're willing to still participate with a 10% chance of death, they probably don't mind about the little rash they're going to get or the elevation in their liver enzymes. And so it was actually quite eye-opening in terms of what patients consider. So previous studies have actually, there have been studies that have focused on asking patients, do you understand what the purpose of this trial is, which I think is a loaded question. So again, phase 1 trials are designed to test toxicity, but clearly have a way or are intended to also look at early signs of efficacy. And for that patient, clearly that's their goal. So there have been studies that have suggested that patients don't understand that and perhaps have, certainly with phase 1 trials in particular, have a lack of understanding of what that is. But the question is it really misunderstanding or is it what we would call therapeutic optimism? And what I mean by that is 60% of patients, when you ask a patient on a phase 1 trial, 60% said that other participants were unlikely to benefit. So they read the consent. You know, you may not benefit from this. I don't think the 60% of people, other people are not likely to benefit. Interestingly, when you ask them, what's the likelihood that you're going to benefit? 3% reported that they were very or somewhat unlikely to benefit, meaning 97% of people thought at some point they were going to benefit from this trial. Now, what that means, I don't know. But it's interesting because is it really a lack of understanding or is it optimism? Is it hope? Is it hoping that perhaps there will be some benefit that comes from this trial to them? Again, whether it's the increased attention, whether it's improved survival, whether it's a response rate, but clearly there is some hope that they would benefit. ASCO is the American Society of Clinical Oncology. They recently put out a position statement on phase 1 trials with the goals to improve coverage. So part of CMS guidelines regarding clinical trial coverage, one of the things that has to be there for Medicare to cover routine cancer care in the setting of a clinical trial is that trial is designed to treat a condition. And so you could argue phase 1 studies of healthy volunteers do not meet that indication. For a cancer patient, again, since every phase 1 clinical trial is going to have a secondary objective of efficacy, it meets that reason, but that is still strongly debated in the field. So improving insurance coverage of care in the setting of phase 1 trials, improving understanding both patient and physician of the goals of phase 1 trials, increasing the number of patients enrolled in phase 1 trials, increasing researcher and sponsor compliance, and then industry support of pediatric phase 1 trials. Unfortunately, still children are in some cases seen as small adults, and so really focusing on pediatric phase 1 trials is important. And I think that's it.
So much. That was great. Before we start with the questions, I forgot one announcement, and that is that, Jen, next week is our graduation basically for our residents, right? Do you have any comments to make? Okay, thanks. Okay, Steve can hardly wait.
One thing I didn't grasp is how long for the dose escalation. Second question.
Yeah. Yeah, so how long are phase 1 trials? So typically patients are treated on study for as long as they're benefiting. Typically there's not interpatient dose escalation. So once you receive a current dose or a single dose, they'll go on to receive that single dose for as long as they're benefiting. Generally, patients are scanned every 6 to 8 weeks on trials like this to evaluate for response, and then they come off the study when they are progressing, when their tumors are progressing. Is that what you meant in as a single patient?
When do you decide the dose escalation?
So if you have a traditional 3+3 design, you treat 3 patients for a full cycle. Generally, that's about a month, several weeks. If there are no dose-limiting toxicities after that period of time, you escalate to the next dose and enroll 3 more patients. And then generally speaking, it's always been dosed. You keep escalating the dose until the maximum tolerated dose, until you see dose-limiting toxicity. Although more and more with the targeted therapies, and especially with immunotherapies even, you're getting to a point where you're not even able to dose escalate further just from a pharmacologic standpoint, but you haven't even reached your maximum tolerated dose. And the hope is that you've hit your target. And but that's where a lot of clinical trials are looking at more at biologically effective dose rather than maximum tolerated dose. Data safety monitoring boards, certainly those are for many of the larger studies, certainly for pharmaceutical sponsored studies, for cooperative NCI sponsored studies, they have central data safety monitoring boards that look at things like this. We here at the Cancer Center have our own institutional data safety monitoring board that will monitor not only investigator-initiated studies that don't have external monitoring, but we also monitor even sponsored and cooperative group studies as well. We only have access to our patient data, so we don't have access to national data, but at least gives us a sense of making sure that we are not seeing unexpected toxicity at our site, making sure we are doing the things we need to ensure our patient safety. But most larger multi-institutional trials will have a central data safety monitoring committee. Yeah, so to diversity, that is a problem in all clinical trials, not even just phase 1, going phase 2 and phase 3. And I think there is certainly literature out there about that. A lot of it comes down to history, right, in terms of experimentation and cultural barriers. There's work being done on that. That is certainly, I think, nationally, there's been a big push to try to increase in diversity in clinical trials because they are predominantly Caucasian. And so a lot of that, I think, has to do with cultural and other demographic concerns. Your second question with respect to kind of whether or not a patient decides to participate in a clinical trial on altruism, I'm not aware of any literature on that, to be honest. I don't know the answer to that, although I do get the sense that sometimes it's more a personal decision, in terms of how that time is spent. One of the reasons I felt so strongly about kind of trying to really build a more robust phase 1 program here is that you can see a lot of those studies came out of MD Anderson, came out of very large sites. Well, if you live here in Louisville, Kentucky, and you have cancer and you're not feeling great and you're going to go on a phase 1 trial where you have to be seen every week, getting on a plane and flying to Houston every week or every month is really not feasible for most people, not affordable for most people. Insurance doesn't cover your plane rides. And secondly, really not the way that you want to spend, the last several months or years of your life. And so I think people who make decisions whether or not to participate, some of it just comes down to personal preferences. I don't know. I'm not aware of any data with respect to altruism, but without a doubt, the most of the cancer patients who participate in studies like this, I almost always hear the comment, well, even if I don't benefit, hopefully someone else will, and I think that that's a strong part of why they do that. Right. It is. So they do. So once you get into phase 2 and phase 3 in particular, your endpoints change from response rate to survival. And so really at the end of the day, even if a drug doesn't cause a partial response, if it stabilizes disease for a year or more, to your point, in theory, you would think it would prolong survival. So when you get to those later phases, assuming it gets through phase 1 and there's enough funding to move it on to phase 2 and it's safe, phase 2 and phase 3 will start to incorporate more. The efficacy endpoints will be survival. And that's where those drugs can shine, even though they might not have great response rates. Yeah. Mm-hmm. I don't know if it's a problem with the informed consent or if it's a problem with the conversation with their primary physician, or if it's just a pure understanding of the term palliative. I think it's interesting. I was working on a project with one of the fellows looking at asking this question, designing a questionnaire to ask patients if they understood the intent of their cancer treatment. Did they think this treatment was going to cure their cancer? And so it's a project kind of ongoing. But one of the parts of that is, how do you word that for a patient? Because most patients don't understand the term palliative. I catch myself sometimes saying, well, we have palliative care, and they go, what's palliative? Palliative is not a term that outside the medical field is widely used. And so it's hard to know exactly the question that was asked of those patients. Was it, do you know that you cannot go on this trial and just get management of your symptoms, or did they use the term palliative? I don't know if it's a problem with the informed consent process. I think the informed consent makes it pretty clear that you may or may not participate. And there is a template, part of the template says, discuss other treatment options, with your doctor, or, you can receive standard care outside of this trial. So I don't know if it's an informed consent process so much as we probably do need to do a better job of that as a whole. Yeah. No, I mean, I think, that's one of my soapboxes is palliative care is not exclusive with active treatment of your cancer and in particular clinical trials. They really go hand in hand. And in order to get patients through treatment, you really need to have great palliative care support. Great. Thank you. Oh. Yeah. Oh, well, thank you.
It's so
Still sewed.
Oh my God, I put it back.
Well, I mean, plug that when I get to my office.
It didn't, yeah, I did, but it didn't like, but I just realized when I saw you were doing something, I thought, because that happens to me all the time, it happens to me on skirts.
No, I know.
Yeah, I know.
Well, that's so funny because I've had this for a year and I've already, thank you. Oh, thank you. Oh, yeah. No, but it's, I mean, yeah, it shouldn't be a big deal. Right. And then through the hospital and then through, yeah.